Welcome once again, and today we are going to continue with colorectal cancer, and we are going to start with the treatment of colorectal cancer. Now, before I start the lecture, from today onwards, I'll not attendance because I get the attendance from Zoom, so we will not take attendance, and you should log on with the devices that are on your name so that I get your names on Zoom, all right? So let's me share the screen with you. And okay, there it is. And I hope you can see the screen, all right? If it's not clear to you, let me know. So treatment of colorectal cancer, there is really nothing much in it. There are just a few drugs that you have, which are 5-fluorouracil, and you have leucovorin, you have irinotecan, you have oxaliplatin, capecitabine. Not many drugs. I'll give you the drug list. So, and as you know that in cancers, we discuss treatments according to the stage of the cancer. So it is these drugs which are used in most of the stages, and in early stages, the treatment is surgery. Sometimes we do give adjuvant therapy, which means giving chemotherapy after the surgery. And in some cases, in very, very early stages, they are not recommended. All right. But there is a little bit of complications, which are only a few slides, which are targeted molecular therapies. So just 3 or 4 slides that you will have to study very carefully, okay, because they are going to be on the test. So surgery is the only curative modality for localized cancer. And when I say localized, I mean stage 1 to stage 3A. Surgical resection potentially provides the only curative option for patients with limited metastatic disease in liver or lung. Now, metastasis, most of the times, we don't do surgeries, but nowadays, people have started doing surgeries in some cancers that have metastasized to the liver or the lungs, and that increases the overall survival to some extent, all right? Although previously we used to say that if there is a metastasis and if you remove, excuse me, if you remove the primary cancer surgically, then the metastatic cancer starts spreading or starts dividing very fast, but that's no more the case. That was a myth that has been dispelled. Adjuvant chemotherapy is the standard for stage 3 disease. And in stage, when you give adjuvant therapy, you have to balance between the adverse effects and the survival benefit that we get. At present, the role of radiation therapy is limited to palliative therapy for selected metastatic sites, such as bone or brain metastasis. Chemotherapy rather than surgery has been the standard treatment for patients for metastatic colorectal cancer. So in metastatic colorectal cancer, this surgery is not the main treatment. This is a sort of adjuvant therapy, which augments the chemotherapy that we give for metastatic colorectal cancer. Biologic agents have assumed a major role in the treatment of metastatic cases, with selection increasingly guided by genetic analysis of the tumor. And we have seen this in lung cancer, and we have seen this in breast cancer as well. We look at a number of mutations that are well-known mutations, and they're also known as driver mutations. So in those cases, we give very specific therapies in combination with the main therapies that we have, particularly in colorectal cancer. The general principles for all operations include removal of the primary tumor with adequate margins, including areas of lymphatic drainage. So this is surgery, which is done in stage 1 and stage 2 of colorectal cancer. And when you do surgery, you must remove sufficient tissue besides the cancer, you have to remove the normal tissue as well, so that on the margins of the resected tissues, there are no cancer cells, okay? And we have seen that in breast cancer as well as in lung cancer as well. So they are known as cancer-free margins of the resected tissue. Standard colectomies for adenocarcinoma of the colon are depicted below. So I've written this as for your reference only, because we are mainly concerned with the therapeutics of the cancers. Okay, so the green area shows the segment of colon that you have removed. And here it is rectum as well. So this is lower anterior resection. You have removed left a little bit of the lower part of the rectum and resected up to the sigmoid. And here it's a little bit higher anterior resection. Then this is known as sigmoid colectomy and hemicolectomy on the left side and on the right side. And a very big operation, total protocolectomy, in which you remove from the anus up to the cecum, you remove everything, okay? So this is just to give you an idea of what sort of surgeries we do depending upon the presentation of the patient. And we have discussed previously that there are some diseases that predispose the patient to the development of colorectal cancer, and that includes adenomatous polyposis coli, APC, and HNPCC, hereditary non-polyposis colorectal cancer, okay, also known as Lynch syndrome, if you remember. So in those cases, sometimes we do these surgeries. And here is just another view. This is a cancer that the patient has, and this is the area of the cancer. So what the surgeon is going to do is he's going to resect over here so that you get cancer-free margins of the resected tissue, okay? So he has removed this part, and then he is going to join this, okay? These two parts, which is known as anastomosis. So cut ends of the colon are joined, okay? So here it is once again. And the important thing to remember over here is that the margins should be cancer-free. Okay, and that is why you send the tissue to the pathologist who looks at the margins, and he will tell you whether they are free from cancer cells, or if he finds any cancer cells over there, then you have to give chemotherapy to eradicate those cells. Now, this is all for reference, but this one you have to include in the examination because it gives you certain indications for total abdominal colectomy with iliorectal anastomosis. And again, as I mentioned, it is hereditary non-polyposis colorectal cancer, HNPCC, which is also known as Lynch syndrome, and familial adenomatous polyposis. I'll show you a picture of this. In this condition, the person gets hundreds of small little polyps in the colon, and there is a very high risk of those polyps transforming into cancers, okay? And metachronous cancers in separate. So sometimes what happens is that you develop a cancer in one part, then maybe away from that in the colon, some distance away, you develop another cancer, okay? It is metachronous when you develop that cancer 6 months after the diagnosis of the primary cancer, and it is known as synchronous if you develop that before 6 months. All right, so this was all about this slide, and here is a picture of familial adenomatous polyposis, and you see these are adenomas. If you count them, 1, 2, 3, 4, 5, 6, and 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. There are hundreds. It's peppered with these small little adenomas, and by the age of 40 years, most probably there is a very high probability that the person will develop the cancer of the colon. Now, metastatic colorectal cancer, chemotherapy is the treatment of choice rather than surgery, and that has been the standard management for patients with metastatic colorectal cancer. Although I said that surgery does have a role, but that's not the primary treatment of colorectal cancer, metastatic colorectal cancer. We do surgeries to remove the metastasis in the liver or the lungs, but it is controversial. Now, the thing is, whether you should, if there is a metastasis, what would you do? Whether you will remove the metastatic cancer first, or you will give chemotherapy first. So it's a bit of controversy. Oncologists, they properly note that major drawbacks of palliative resection will lead to loss of performance status and risk of surgical complications that can potentially lead to delay in chemotherapy. And the earlier we start chemotherapy, the better it is, because the cells are mutating all the time. The cancer cells are developing resistance against the drugs because of the genetic mutations they are developing. Okay, so the oncologists feel that it's better to give chemotherapy first, but then the surgeons argue that if you do elective surgery, then it's much better than the emergency operations in patients who are receiving chemotherapy. For example, if there is obstruction of the colon or the large bowel, then obviously that is an emergency. And the patient who is receiving chemotherapy, he might bleed more, or there might be delay in the healing of the surgical wound. All right, so these are complications, but obviously the team has to form a judgment, and it is a combined decision of the oncologist, the surgeon, the pharmacist, and the radio-oncologist. All of these people are involved in making a decision. Oncology nurses are also included in that. So curative intent resections of liver metastasis have significantly improved long-term survival with acceptable post-operative morbidity, including in older patients. So they are good, they do work well, but every patient with cancer, not only colorectal cancer, any other cancer, has to be evaluated individually. Okay, you have to make a decision which is specific for that patient. Okay, that is known as individualized treatment for that patient. Now, there are other methods besides surgery for removing the metastatic cancers. Potentially, these are also potentially curative treatments for those who are not surgical candidates. And there are certain ablation techniques. Cryotherapy is one of them, in which you use probes to freeze the tumors and the surrounding hepatic parenchyma. But, it has got complications. It results in significant morbidity, including cracking of the liver, thrombocytopenia, disseminated intravascular coagulation. So, it is a trade-off. Then radio frequency ablation, which is a better option. You use probes that heat liver tumors and the surrounding margins of the tissue, and they create coagulation necrosis. So radio frequency ablation has minimal morbidity, so it is much better than this. And, these therapies, we will come to them when we do benign prostatic hyperplasia, because we have got a lot of laser therapies and radio frequency ablation, microwave ablation in removing the prostatic adenomas, which are benign. Okay, right. So here is the drug list. And as usual, you have to memorize the drug list, because I ask questions from the drug list. So antimetabolites are 5-fluorouracil and capecitabine. And there is another one, which is Tagafor. I don't know why it's not here, but capecitabine is a prodrug for 5-fluorouracil. We have leucovorin, which is a folic acid antagonist, then miscellaneous agents, irinotecan, tipiracil, trifluridine. The brand name is Lonsurf. This was approved in the last 4 or 5 years, perhaps, or maybe in 2015, I'm not sure. But this is relatively newer drugs. Alkylating agents, we have oxaliplatin, that is very commonly used in colorectal cancer. Then we have got monoclonal antibodies that include cetuximab and bevacizumab. This cetuximab and panitumumab, these are anti-EGFR antibodies. Bevacizumab is an vascular endothelial growth factor receptor antagonist. and ipilimumab is CTLA4 blocker, cytotoxic T lymphocyte antigen 4. I think I've given it in your handout. If not, please let me know. I'll give you, but I have mentioned it at some other places, okay? Now, tyrosine kinase inhibitors, we have got aflibercept and regorafenib. VEGF inhibitor, we have got a newer one, which is ramucirumab, and this is also a VEGF inhibitor, bevacizumab, okay? Then we have got programmed cell death receptor and programmed cell death ligands. I'll show you a diagram in the end of the lecture, and you'll understand what these receptor and ligands are doing. So pembrolizumab and nivolumab, these are the drugs which are used over here. Then we have got larotrectinib and entrectinib. We have got BRAF kinase inhibitors, which are used in very specific situations. All of these targeted therapies are used with specific genetic mutations. So encorafenib and vemurafenib and dabrafenib, these are the drugs. Then MEK inhibitors, trametinib and binimetinib, okay? So you have to memorize all these drugs and the groups. Now, treatment 5-fluorouracil remains the backbone of chemotherapy regimens for colon cancer, and also in adjuvant setting and also in metastatic setting. In addition to 5-FU, we have got other drugs like capecitabine and Tegafur or Tagafood, whatever you want to call it. Both of these are prodrugs for 5-fluorouracil, which means in the body they are metabolized to 5-fluorouracil, and they are increasingly used as monotherapy or in combination with oxaliplatin and irinotecan. Now, this is a table which gives you certain protocols for treatment of colorectal cancer, and it says that it will be included on the test. So you have to memorize this one because this is important. You have to memorize at least some protocols, and you see what do we have in them. In all of them, we have 5-fluorouracil, leucovorin, and oxaliplatin, or capecitabine, which is a prodrug for 5-fluorouracil. Oxaliplatin, everywhere it is, or leucovorin, 5-fluorouracil. Everywhere we have the same thing, some addition, irinotecan, capecitabine, irinotecan. So it is the same drugs that we are combining in different ways, okay? And if you see over here, these two protocols have the same drugs, right? But then what's the difference? The dosing schedule is different. These two have the same drugs, but oxaliplatin dosing is different, okay? So they have got different names or nomenclature. The benefits of adjuvant therapy. Adjuvant chemotherapy provides a significant disease-free survival benefit in stage 3 colon cancer because it reduces the recurrence rate. So although I have mentioned that whenever the surgeon resects the tumor, he also resects a lot of normal tissue with that, particularly in the bowel, because we have got a lot of room in the bowel to remove extra tissue. You know, the small bowel, although we don't get a lot of cancers of the small bowel, but this colorectal cancer, even the colon is 5 or 6 feet long. So we do have space, or we do have room to remove extra tissue, okay? But even with that, sometimes we have micrometastasis, right? Which might have gone to the lymph nodes or some other part in the body. And we had the same thing in breast cancer, if you remember. We give adjuvant therapy to eradicate the micrometastasis that could be present over there. But then it depends that how many cycles will you give and for how long will you give, you know, that's an issue that you have to decide. So duration of the therapy in patients with FOLFOX or KPOX, 3-year disease-free survival is lower in 3 months than in 6 months, okay? So you're giving this treatment, oxaliplatin, in both of them. So if you give it for 3 months, the recurrence rate or the disease-free survival is smaller. Okay, so if you give it for a longer time, then the disease-free survival is longer, but on the other hand, the side effects may be more with 6 months treatment. So 3-month therapy is associated with less neurotoxicity, which is because of oxaliplatin. And for stage 3 colon cancer, if it is a low risk, I'll show you in one of the later slides that what do I mean by low risk and high risk. So low risk, this Capox, capecitabine, oxaliplatin for 3 months and FOLFOX for 3 to 6 months. In high risk, we give it for 6 months. So here you have a choice, 3 months or 6 months, but here most of the times the oncologist will decide to give this therapy for 6 months, okay? So stage 1 disease and low risk stage 2 disease with high microsatellite instability. I'll explain that to you in a minute. No adjuvant therapy is required because the cancer is localized, very limited, and it can easily be removed with surgeries. And we have seen in clinical trials that surgery works very well, and we don't need adjuvant therapy because of the side effects. We do not have to expose the patient to the side effects of these drugs unnecessarily. Right, patients with low risk stage 2 disease may be, so not must, may be considered for 6 or 3 months of capecitabine or 5-fluorouracil plus leucovorin. High risk stage 2, you can either give 5-fluorouracil or capecitabine, or you have got other options with oxaliplatin, FOLFOX regimen, Capox regimen, okay? Or observation without adjuvant therapy is also an option. So as I said, you have got what I'm showing you are the options. The actual decision has to be made as a team by all those who are involved in treatment of the patient, okay? Right, so stage 2, the American Society of Clinical Oncology does not recommend routine adjuvant chemotherapy for patients with stage 2 colon cancer. So that is why over here we had written may be considered. We are not saying that it must be given. So for patients with stage 2 colon cancer, instead recommends encouraging these patients to participate in clinical trials. It's up to the patient, you know, in clinical trials. We have to take the patient's consent. So if he wants, he can take part in clinical trials. Surgery alone is usually curative for stage 2 colon cancer. And high-risk CRC patients, one clinical trial is comparing following therapies, which are again, you know, oxaliplatin, leucovorin, and 5-fluorouracil with bevacizumab, which is a vascular endothelial growth factor competitive inhibitor. And you know, if you remember in breast cancer, I mentioned that previously bevacizumab was approved for treatment of breast cancer in certain cases, but lately the FDA has revoked that approval, and because many clinical trials have found that bevacizumab is not doing much benefit to the patient, okay? So this clinical trial is comparing oxaliplatin, leucovorin, 5-fluorouracil with or without bevacizumab. Now, what is high risk stage 2 or what is high risk stage 3? We have been discussing that. Well, stage 3B is always chemotherapy, but we often differentiate stage 2 into low risk and high risk. So high risk patients, about 20% of the patients that we get with stage 2 are high risk patients, and they are defined as those with a higher recurrence rates. And the factors that determine whether they are high risk or low risk are as follows: pathological T4, which means large tumor size, poorly differentiated, which is histological grade, which is higher, then preoperative carcinoembryonic antigen. And I have, well, not yet, but when we go to prostate cancer, we have another biological marker, which is known as prostate specific antigen. But you know, if it is more than 5 nanogram per ml, this is the normal range. Then lymphatic venous invasion, positive resection margins that we discussed just a little while ago. bowel perforation and obstruction. When a patient comes with bowel perforation and obstruction, then the prognosis is not good, okay, for this colorectal cancer. Then this is microsatellite stability with loss of heterozygosity, which we discussed last time. And we can get microsatellite instability with loss of heterozygosity, okay? So what is microsatellite instability? It is a condition of genetic hypermutability, which means that mutations are happening very rapidly. Okay, that is what hypermutability means. And what is a microsatellite? Microsatellites are small regions, the non-coding regions of the DNA, maybe 4 to 6 or 2 to 6 nucleotides long, which are repeated many, many times, 10, 20, 40, 50, or maybe 100 times. So they are known as microsatellite regions. Instability means they are not replicated very accurately, okay? And what does that indicate? It indicates that the mismatch repair system is not working. So the cancer is going to develop more mutations. And when a cancer cell develops more mutations, there is a possibility that it will develop a mutation which will make it resistant to the drugs, or which will confer a survival advantage on that tumor cell, which means it will multiply faster or it will not be detected by the immune system. Okay, so mismatch repair gene or system mutation or impairment is a common finding, particularly in colorectal cancers. So the presence of microsatellite instability indicates that mismatch repair system is not functioning properly, okay? Treatment of stage 3. Adjuvant chemotherapy should be considered in elderly patients with stage 3. Now, stage 3 is divided into stage 3A and stage 3B. Stage 3A is again divided into high risk and low risk, okay? So adjuvant chemotherapy reduces the risk of distant recurrence after surgery by about half in both elderly patients. So if it is stage 3A, the guidelines recommend surgery and adjuvant chemotherapy. And what we are seeing over here is that adjuvant chemotherapy will reduce by half the rate of recurrence, which means that the progression-free survival will be increased in those patients, okay? Addition of oxaliplatin to fluorouracil demonstrates a significant improvement in 3-year disease-free survival of patients with stage 3 colon cancer. So again, you know, same, that's why I asked you to memorize these few protocols with a very few drugs. It's not difficult, okay? Capecitabine is non-inferior as compared to fluorouracil. Now, non-inferior, remember, does not mean or does not necessarily mean it has the same efficacy. We will discuss non-inferior some other time, but capecitabine is non-inferior means that due to various factors, we can use capecitabine in place of fluorouracil and leucovorin. So if you have got a low risk patient with stage 3, and this is what low risk means, okay, we use Folfox for 6 months or Capox for 3 months. Same drugs that we have used for stage 2. High risk, which means, you know, larger tumor size or more lymph nodes are involved, then we use for 6 months the same regimen for 6 months, okay? Now, what about the follow-up care in stage 2 and stage 3 cancers? You don't have to memorize, you know, these things, the durations or the periods after which you have to repeat them, but, you know, history and physical examination you have to do. The durations after which you have to do them are given over here. Carcinoembryonic antigen, 3 to 6 months. Chest CT scan to see metastasis, you know, 1 to 5 years. Colonoscopy, 1 year, 3 year, 5 year, depends, okay? And abdominal CT again to see if the cancer has extended or if there is any peritoneal involvement or any other metastasis in the liver or somewhere else. Okay, right. So therapy for metastatic disease. Combination regimens provide improved efficacy and prolonged progression-free survival. Now, progression-free survival, I hope you understand what I mean by that. It is the period in which the patient has no evidence of cancer in his body, okay? So, although we don't have any definitive cure for this, which is unfortunate, but overall survival might be increased, okay? The availability of new classes of active drugs and biologic for colorectal cancer has improved the expected survival of patients with metastatic disease. So now I'll explain to you, we have these regimens that I've already explained to you, and I'm going to explain to you a few biologic agents which are given in the drug list as well. And these are only 3 or 4 slides which involve a little bit of memorization, okay? It's not too difficult. So in 2015, FDA approved tipiracil and trifluridine for metastatic colorectal cancer for patients who received previous treatment with fluorouracil or capecitabine or oxaliplatin or irinotecan, and those therapies were not successful, or there has been a recurrence of the cancer. And these are the biologic agents that we commonly use: bevacizumab, cetuximab, nivolumab, panitumumab, pembrolizumab. These 2 drugs are programmed cell death ligand blockers or receptor blockers, okay? This cetuximab and panitumumab are EGFR antagonists. Bevacizumab, I've explained to you that we have this vascular endothelial growth factor competitive inhibitor. Okay, so molecular targeted therapy, this BRAF V600E mutated. Now, BRAF is a gene that I have given previously. I've explained to you, you don't have to memorize the names or what BRAF stands for. You know, there are sometimes very strange names. But V600E means, you know, it is a big gene at position 600. Valine has been replaced by glutamic acid. So it was valine, but it has now been, due to mutation, it has been replaced by glutamic acid, okay? So in CRC, unresponsive to oxaliplatin-based therapy without irinotecan, the NCCN guidelines include any of the following options. So irinotecan plus vemurafenib, which is used in this case, plus cetuximab or panitumumab. Okay, they are both EGFR antagonists. Then dabrafenib, again, same group, plus tramatinib, plus cetuximab and panitumumab. Okay, these 2 will appear everywhere. And we are giving, there are 3 drugs in this group, okay? So any one of them, we are using them with this. Then encorafenib, the 3rd drug, plus bimimetinib, plus cetuximab and panitumumab, okay? So BRAF V600 mutation is a mutation of BRAF gene in which valine is substituted by glutamic acid at amino acid 600, okay? So it's a big protein, more than 600 amino acids, which is made by this gene. Okay, so other targeted therapies for metastatic colorectal cancer, larotrectinib and entrectinib are treatment options for patients with metastatic CRC with NRTK gene fusion. So we have to do genetic analysis. If it is available, we do that. This neurotropic tyrosine receptor kinase gene over here. Then in the first line setting, nivolumab and pembrolizumab, first line, okay, or a combination of nivolumab and ipilimumab are listed as a category 2B. So category 2B, you know, we have these categories of recommendations. Category 1 recommendation is a very strong recommendation. If I say that I have a category 1 recommendation, it means it is based on many controlled, randomized controlled clinical trials, and they all have found very strong evidence of the efficacy of the drug. Okay, so that is category 1. Category 2 is in between. 2B is even lower. It's not a strong recommendation. It's a weak recommendation. So we have this for patients with the mismatch repair gene deficient patients or high microsatellite instability who are not appropriate candidates for treatment with cytotoxic combinations. Okay. Right. And ipilimumab is CTLA-4 blocking antibody, which is the mechanism of action. Modified FOLFIRI, which includes fluorouracil, leucovorin, oxaliplatin, irinotecan, plus panitumumab or cetuximab, is recommended for patients with unresectable metastatic colorectal cancer. Now, that's why I said that this is a little bit complicated. This is being used in a very, very specific situation, right? So the cancer is unresectable, it is metastatic. There is some synchronous liver or lung metastasis, and these genes are not mutated. You know, wild type means not mutated. And the tumor is left-sided. So a lot of conditions are there for the use of this gene. So that is I guess that is the only difficult part, these 2 or 3 slides. Now we go on to radiation therapy. Radiation therapy does not work very well. It's not indicated. It remains a standard modality for patients with rectal cancers. It has only limited role in colon cancers. And when this radiation therapy for rectal cancer is given with 5-fluorouracil, then they augment each other's effect. Okay. Radiation therapy is not used in adjuvant setting. It is only used as palliative therapy for bone or brain metastasis. Obviously, we cannot do surgeries in the bones, and we do not unnecessarily open the brain. Stereotactic radiotherapy, also known as cyberknife, which is used radioembolization with yttrium-90. You know, then we have got other ways, microspheres of yttrium-90 resin. So different ways of giving radiation therapy, but it is a standard modality for rectal cancer and for palliative therapy. Okay, so that's all about radiation therapy. And diet, we have already discussed that high fiber diet is good even after, it is protective as well as after you start the treatment. Switching over to high fiber diet is good. And there are 2 types of high fiber diet. One is cereals, which are better. And then you have got survival rates for higher in patients who increase their fiber intake after diagnosis from levels before diagnosis. And whole grain, you find a lot of whole grain products in these big shops like Danube and this Carrefour or whatever. So cereal fiber was associated with lower CRC specific mortality. They reduce mortality to some extent. And vegetable fiber is also very good, but they are claiming that cereal fiber is better than vegetable fiber because the mortality was, better in cereal fiber. Okay. No association was found with fruit fiber. So the bottom line is that cereal fiber is better than vegetable fiber, and overall any type of fiber in the diet is good for a patient who has got colorectal cancer, and it is also good for prevention of colorectal cancer. And this is the last slide. Colorectal cancer prevention strategies, 3 categories: screening. We have seen that stool test and colonoscopy and some other tests. Lifestyle measures, which include physical activity. I've given a list over here. Pharmacological prevention, right? So weight loss, smoking, they say, is protective, but smoking is not recommended for the other diseases that are caused by smoking. Alcohol intake, again, not recommended. Diet, calcium, vitamin D supplementations, and pharmacological prevention. Celecoxib is there, COX-2 inhibitor. Aspirin, we discussed. Sulindac for familial adenomatous polyposis coli patients. Okay, and I think that is all for this lecture, and we have completed it well in time. There is still some time to go, and so we'll not go away. We will start with lymphomas, and today we are going to do Hodgkin lymphoma, right? Again, there are about 40 slides, and I hope to complete that in 1 hour or in a little over 1 hour. All right. So if you have got any questions, you can ask me now. Otherwise, we will take a 15 minutes break, and please come back in time, because I get the times on Moodle. So that's why sometimes I mark some people absent if they have attended only 16 minutes or 20 minutes in the 3-hour session. So they'll be marked present only for one session. All right. So any questions? So I'm assuming there are no questions. I will stop the recording, and please remind me to start the recording once again.